Philomenian College of Cardiology, Prof. Cardiological Studies, Philomenian College of Cardiology, and State-elect Chapter Cardiological Research in India. He is convener National International Cardiological Society of India. He is the fellow of ECR Society of Cardiology, and he is the editorial board of Indian Head Heart Journal, Cardiology to Indian Journal of Cardiology. He is going to talk on advantage and disadvantage of statin therapy.
Thank you, Chairperson, for kind introduction, and thank you, organizers. In fact, I enjoy getting to interact with non-cardiologists. Cardiology seems to be getting boring, and I'm sure I learn a lot from these meetings. I very much enjoyed Dr. Sarita Bajaj's lecture. Just before we start the talk, I think I have a couple of suggestions which I have always been giving to my fellow colleagues. Maybe they are not taken up. If we are holding a meeting on diabetes or cardiology, the moment we get out of the hall, we pounce upon perhaps the McDonald's lunch that organizers very kindly provide to us. And there are lavish dinners, very heavy calorie lunches, snacks. I think we should perhaps set a model and try and give a healthy food. That should have been done a long ago. And at least whenever I try to hold meetings, I try to stick to that as far as possible. I understand it's not always very easy. But anyway, that's just to say that charity begins at home. We have to set ourselves right, our habits right, and demonstrate to the public in general before we start sermonizing. Anyway, so over the next 20 minutes, this topic was given by Dr. Nagar, advantages and disadvantages. So I thought a lot about it. There seem to be all the advantages. So I had to hunt the literature for some disadvantages also. And I'll try to present to you a balanced view of whatever little I could get from the net in my previous presentation. We all know that diabetes is not only blood sugar, and it is intricately connected to so many other things. So as you can see here also, in the pathophysiology you have the lipid arm also, which is very active. So basically, it's not only that diabetes may be promoted by dyslipidemia or vice versa also. You know there are diabetic dyslipidemia. But both of them are very important factors for endothelial dysfunction, which is perhaps the baseline for the starting of any vascular disease and in long-term any vascular complication. So perhaps they are going, if not hand in hand or glove in glove, they are going along parallel paths, and they are very likely to sort of intermerge. There was another thought that the LDL in diabetes is different, as there was an ad many years back that something is different. So this is known as the ultra bad or super sticky LDL cholesterol. It's not, well, I don't think there's any specific measure that we can need to take to detect or lower this super sticky cholesterol, but perhaps we'll come to hear about it more in the future. We all know with the same measurement of LDL, you can be worse off, especially if you have high density LDL, as is demonstrated here. So you have more LDL particles, so perhaps it's the number of particles which matters. And the diabetes LDL particles, you have a normal LDL cholesterol level, but still the concentration of ApoB and LDL is more. So this also increases the risk. Why I have spent just 5 slides on this is that both these conditions are intricately related, not only from pathophysiology, causation, to the disease development, and even to the ultimate development of vascular complications. This is a very commonly seen slide where we try and explain even to the public that it's not that you develop atherosclerosis in the flash of a second. It's a long drawn out process. I'm sure that holds true even for diabetes. So we have to keep on stressing that even pre-diabetes metabolic syndrome are equally troublesome features. So now coming to the crux of the matter, this was a very large meta-analysis of more than 20,000 patients who had been studied in 14 randomized trials, and these 20,000 patients were diabetics. So these are the diabetic subgroup extracted from these 14 randomized trials, which together had more than 150,000 patients. So, and these are the list of trials that were included in the analysis. So as we see, we need not go into very specific. There were 20 charts. I have just taken out 4 of them. The effects on cause-specific mortality, reduction by LDL cholesterol. So as you can see, whether you have diabetes or you don't have diabetes, you stand to benefit. In some reasons, the diabetics may benefit more, in some the diabetics may benefit slightly less. But again, these are figures from a very large population subset. Even the effects on major vascular events, because what we are concerned about, I'm sure all of you know that most of the diabetics don't die from diabetes, they die from complications. Vascular events being the top rank complication attributed to be perhaps the savior. But first the AIM high and then the HPS2 study have literally punctured the theory, at least for the time being. There may be some other way that we can get around to raising the HPS. One is the infusion that the melano even melano gene. But then again, it's not practical. And some new drugs are being tried out. We'll not go into that. So where has the focus of the guidelines shifted? We are only talking about reduce the LDL, raise the HDL, do exercise. Now, since last 2 or 3 years, all the major European and American associations are focusing on, first of all, calculating the systemic coronary risk estimation score, and only then trying to put the guidelines into action. Now, this is not very difficult. There are many tables, many graphs. Even most of you have an iPad now or a smartphone. You just download it, enter the patient values, and gives you the risk score. I have tried to make it a common practice in our ICU and wards that every patient's risk score should be calculated and mentioned in the file. Anyway, so we know that very high cardiovascular risk are those who are already known to have vascular disease or diabetes, or the score is more than 10%. And chronic kidney disease is also now coming up as a vascular risk factor. So what is this meaning of 10%? So see the bottom paragraph. The score system estimates the 10-year risk of a first fatal atherosclerotic vascular event, which may be in any vascular bed. It is not necessarily coronary or brain. So if the score is more than 10%, so you have a 10-year risk of more than 10% chance of a first fatal event. So that is a very high risk subset. These are one of the charts anyway, you won't go into that. So the focus now is that, fine, focus on cholesterol and subfractions, but also focus on the global risk score. What else can be said about the side effects of the statins? Now these are very, very large databases. Nearly 30,000 patients have been followed up and analyzed for these side effects. And if you see these side effects which are mostly very feared are one is rise in liver enzymes, which can go sky high or cause even liver failure. Although let me tell you, liver failure is very, very, very rare. Rise in CPK and muscle pain, even leading to rhabdomyolysis. You can see even in high dose, the events are less or just around 1%. So that's not really a very great side effect. But yes, it can occur. In clinical trials, even in one trial which has been held in India in 6 centers, high dose atorvastatin 80 milligrams. It was very, very well tolerated. There was no case of death, etc., and very low incidence of serious side effects. Really very low. In fact, what has been seen that in patients in this PIECE study, abnormal liver function test patients performed better in terms of getting the benefit from the statins. Now this was a slight paradox, and what was even mooted at one point, that the statins can improve the liver function in patients with abnormal liver tests. I won't advise anybody to try that, but yes, this is what we mooted at some point. And what is generally felt is that even if a patient comes to us and has some slight elevation of liver enzymes, there may be some of our fellow physicians who may feel some hesitation in writing a statin. Please get over it. There is absolutely no problem unless the patient is even having clinical jaundice. I have tried a statin if the patient really needs it and there has been no really serious side effect. And what is now going to come in the guideline is that liver tests before starting statin are irrelevant. And if at all you want to do it, just do it after 10 to 12 weeks and you will be reassured. Now, it is not that this was the picture right from the start. The initial statins, the fluvastatin, cerevastatin, etc., could have had a higher incidence of abnormal rise in liver enzymes. But if you see the modern day statins, that is atorvastatin and rosuvastatin, they are really very low. And the benefit you get is very, very much. The same goes for muscle effects. So if you see the benefit versus risk, leave out these older statins, but the modern day statins have a very good benefit to risk factor profile. For example, this is a anagram that number needed to treat. I just take 5 records. Number needed to cause a GI bleed by aspirin is 248. So if you give aspirin to 250 patients, one will have a GIG. And if you give it to 2000 patients, one will have a fatal GIG. Number needed to cause severe myositis by statin is 100,000. And number needed to cause fatal myositis is 1,000. So it's really very, very, very low and rare. The last question we are going to address: increasing incidence of diabetes by statin therapy. I am sure most of you are well informed on that. But there was a fear that there was a 2 to 3% increased incidence of new onset diabetes on long-term statin therapy. But we see from subsequent slides that the benefits far outweigh this slightly increased risk of diabetes. So one thing is that yes, the large patient volume data confirms that this is the case, but still the benefits are too many. So if you can see here, if you give 250 patients statins for 4 years, so that is 1000 patients for 1 year, then there will be one excess case of diabetes diagnosis. But on the other hand, you are going to prevent 5 to 10 cases of myocardial infarction. So balancing the benefits of statins versus new risk diabetes, I mean, risk is there theoretically, but very, very small, and the benefit is tremendous. 5 myocardial infarctions prevented, equal number of other vascular events prevented, even deaths. the there have been some studies which have not shown any risk, like European studies, but there are certain confounding factors. So why should statins increase the risk? Is it due to decreasing the insulin secretion or reducing the sensitivity? I don't have a clear answer. Perhaps your forum is better knowledgeable on that. But anyway, even accepting that the statins increase the risk of new onset diabetes by a very small amount, it can be sort of, when you prescribe a statin, you are also prescribing healthy lifestyle measures which are going to positively benefit the patient or reduce the incidence of new onset diabetes. And benefits, as I have shown, far, far outweigh the risk of new onset diabetes. So, whether the patient is diabetic or not, the statins are very useful. And just concentrate on the last sentence, that the debate about whether all patients with type 2 diabetes warrant a statin therapy should perhaps now focus on whether there are any patients at sufficiently low risk for this safe and efficacious treatment called the statin to be denied or withheld. So, the day is not far off when statins can perhaps be translated to something like a vitamin therapy. And believe me, they will benefit most of us, unless and until we improve our lifestyle. So, as this was said, now the next few slides are not related to the topic. They were just, I picked up from Dr. Salim Yusuf when we interacted during the course of Q3 trials. This is his favorite slide. The diabetes is a cardiovascular disease which you diagnose by measuring blood glucose. But you do not necessarily treat it by only controlling blood glucose. The mortality benefit in diabetics, now this is from his Hamilton, the Institute of Population Studies, that the mortality benefit in diabetics is greatest if you are reducing the percentage greatest. You are reducing the blood pressure, lesser with lipid management, and least with blood sugar control. But anyway, all three are important. So let me finish off the talk here and say that the statins are a wonder drug, no doubt. Don't use them indiscriminately. I am not promoting that they should be given to all, but perhaps try to assess the risk profile of the person sitting across the table in your consultation chamber and then decide what is good for the patient. Thank you very much.
It was a very good topic and Dr. discussion. Dr. Sinha has covered all the latest views on the use of the statins in cardiovascular system as well as the diabetes patients. And he has also given a role of statins and the relation of the statins or cardiovascular disease, that is suggestions the systolic blood pressure and the prognosis. These statins may have some hesitation to increase the incidences of diabetes mellitus, but it is still a question of the newer research. These statins may have any effect on the function of the beta cells or other parameters of the disease. Thank you very much.
Thank you, sir. I request our chairperson to please present a moment to Dr. Sinha. Sir, please, Mr. Sinha. I call upon Dr. A.K. Srivastava from Railways and Dr. A.K. Singh to present mementos to our chairperson.